Thank you so much. It's truly my great honor to be here and to share some of my ideas with you as well. So in this talk, only very limited morphology will be touched, and most of my talk will be related to the practice in the precision oncology era. As a pathologist, how can we do and why? It's my disclosure as a long list. However, the most important is that the opinions I give is that of my own, but not any commercial party. It's a complex flow chart. I would like to highlight that the NGS for non-small cell lung cancer has been reimbursed in Taiwan since May this year. And the reimbursement has several rules. The first one is that it's fixed reimbursement. So for small NGS panel that is genes no more than 100, the reimbursement is around $600, not too much. And for large panel, more than 100 genes, the reimbursement is around $1,000. 1,000. Again, not too much. And it's once in the patient's lifetime reimbursement. It means that a patient can have the NGS reimbursement only once throughout his disease process. And since most NGS panel cost much higher than the reimbursement, so most patients have to pay out-of-pocket expenses for their NGS service. For non-small cell lung cancer, the gene panel must contain EGFR mutation or fusion, etc. So only non-squamous non-small cell lung cancer can have the reimbursement for the metastatic setting or disease recurrence, and only when the curative therapy cannot be applied or progression on the first-line TKI treatment. Or for patients with stage 3B and 3C disease, because some 3B and 3C disease will be resectable. Only when the multidisciplinary team consensus indicates this patient might not be eligible for surgery, CCRT, or radiation therapy, and also cannot receive curative surgery or progression, the patient can have the reimbursement. So our national health insurance really encourage the EGFR first testing setting. For fresh case, the patient can have EGFR test at the beginning, and if the EGFR is positive, it's stopped because the patient can receive EGFR therapy. And if the EGFR is negative, the patient can have OAK and ROS1 and then PD-L1. And he can also have NGS tests in parallel. So if a patient wants to have upfront NGS test, it means that they want to have NGS test at the initial diagnosis. If the NGS shows the patient is positive for EGFR, only the EGFR will be reimbursed. It's around $200. And if the EGFR is negative, the NGS will be reimbursed, and the patient can receive OAK and ROS1 and PD-L1 at the same time. So the reason why we want to have the test in the EGFR first setting is because around 55% of non-small cell lung cancer in Taiwan harbor EGFR mutation. So it's more cost-effective and also time-saving. And for the progression setting, irrespective of EGFR status, the patient can have EGFR test. So during the past months, we are getting realize that NGS can be very useful, but we have some challenges. The first one is that our reimbursement encourage a small NGS panel with only essential genes. However, we let more genes should be tested, so usually large panels are preferred. For the emergent therapeutic targets such as NRG1 and FGFR2 and 3, they are druggable. However, in our limited NGS reimbursement panel, they are not included. But sometimes we see NRG1 positive, fusion positive tumors. And we also learned that for immunotherapy, there are many predictive biomarkers such as NTK11 and TP1 mutation should be profiled. So the problem is how large is enough for routine practice. We, in our institute, we provide large panels, more than 500 genes, and also the panel around 40 genes, and also for 17 genes. Our clinicians more prefer the small to medium size panel because it seems to be 1/5 all NGS panel. And for such a panel, including these genes, includes almost all genes should be profiled for non-small cell lung cancer, the driver events, and also the predictive events such as KIP1 and STK11. What is interesting is that this panel is widely used in our institute because of it could be very helpful for such as endometrial cancer because you see POE mutation here and TP53 here, so it will be very helpful. And also for the medullary thyroid cancer and biliary tract cancer because FGFR2 is now druggable in biliary tract cancer. So large panel is good, but usually a medium-sized panel would work better in the clinical area. So this is an example, a lung biopsy. And in this biopsy, my first impression is that it could be a metastatic adenocarcinoma from colon because you see mucinous carcinoma. But after a detailed survey, we confirmed that it is a invasive mucinous carcinoma of lung. And based on the literature, we learned the invasive mucinous carcinoma has a little bit higher frequency other NRG1 fusion. So it's a wonderful example. We profile this case using the panel mentioned earlier. We identified NRG1 fusion. And this is multi-type case, a lung cancer with nodal metastasis. As you can see, the morphology feature is not like usual adenocarcinoma of lung. It shows slender micropapillary and the cell morphology are relatively uniform with coagulous nuclei. And again, we identified NRG1 gene fusion. And next challenge is that tissue adequacy. In the era of NGS reimbursement, many patients want to have NGS service, but the problem is that do we have enough tissue? If not, it seems that we have to apply alternative diagnosis strategies. As a referral cancer, we in our laboratory receive increasing volume of cases, and more than one-half of them are not adequate for NGS. They are too small, or the tumor purity is too low. So there are two issues. The first one is that we have to educate our pathology to minimize unnecessary IgG staining. For usual non-small cell lung cancer, usually P40 and the PPF1 would be very helpful. Only two stainings could work quite well. And we also have to apply multi-gene tests for those inadequate for NGS. For example, on the left is our routine practice, what we think. On the bottom, I think in this case might be adequate for NGS, but the upper panel, you can see the tumor tissue getting small and small and small. Even on the top, you can see that you cannot see any tumor fragment based on your naked eye. But if you check that under microscope, yes, there are some tumor cells, only some. And this is another case. Yes, the tumor area is large, but the sample is large, while the tumor area is quite limited. Most of them are fibroblasts and inflammatory cells, and only foci contains tumor element. So both situations are quite common, but for these cases, NGS might not be feasible. So we, in our institute, have such practice. If the patients would like to have multi-gene tests such as NGS, and the tissue is adequate for that, yes, we will perform NGS for DNA and RNA for mutation and fusion at the same time for this patient. But if the patient asks for a shorter time for a low cost and for those with tissue inadequacy, we will perform multiplex PCR. And to date, the most powerful multiplex PCR will be from Amol. It can provide a list of genes for mutation such as EGFR, BRAF, ERB2, and KRAS, and also fusions. What is amazing is that the successful rate is very high. It's approximately 99 to 100% for any biopsy cases, and also cover a wide range of mutation types. And here is our observation. Last year, based on a limited number of cases, in the 500 cases who are native to EGFR, OAK, and ROS1, we call it PET-native non-small cell lung cancer, because without further testing, these cases can only receive immunotherapy or chemotherapy. But if you profile these cases more detailedly using NGS, or in this case, is from Amol PLC, using Amol PLC, 40% of them can have driver events, 40%, and most of them are druggable. So if you profile these cases, you can have a large number of HER2 insertion, and sometimes you can also see EGFR mutation. That is because some commercial platforms from Comas or Kyogen are not so sensitive. And you can see KRAS G12C. We learned that for some driver events, they might not have drug at the present stage, but they might have clinical trial. So if you really have some clinical trial in your institute, this will be very helpful. And here I would like to highlight two genome operation patents, the MET and RAPE, because we in Taiwan we just received reimbursement for these two genes for the inhibitor. And I would like to show you the morphology spectrum of these uncommon driver events. So again, this is a quite large biopsy, but the tumor percentage is quite low. Most of the specimen contains only blood clots, as shown here. And on the limited foci of cancer cells, you can see a little bit polymorphic tumor cells, but there is neither granular or clear squamous differentiation. It's a case with MET exon 40 skipping, and this is another case. The biopsy is not too large, but the tumor purity is relatively higher. It's approximately 40 to 50% tumor purity, so it's adequate for both NGS or real-time PCR. Again, it's MET exon 40 skipping. And here are 6 additional cases we identified during the past 3 months for MET exon 40 skipping, only in 3 months. And you can see it's quite atypical for an adenocarcinoma, intensive intracellular mucin and flat tumor cells. And here, a little bit squamous differentiation, and here, tubular structure, and for the lower panel, a little bit polymorphic and even spindly, and here, a little bit polymorphic. So if you see a tumor native for EGFR mutation, but with a typical morphology, please remember to perform multi-gene test or NGS, because it very likely harbor uncommon driver events. And the next one is red gene fusion. Again, the tissue is adequate and contains a large tumor fragment. To me, it's large enough. It's red gene fusion. However, for these large samples, you can see only very limited tumor foci here, here, and here, and here, among the many tissue fragments. So it's not possible for NGS. But we usually see such cases. It's MET fusion. And there are 3 cases in a panel with red gene fusion. You can see on the left, micropapillary pattern and rhabdoid feature, and in the middle, in the low power, the spindly polymorphic with glassy cytoplasm, also some kind of rhabdoid feature. And here is very likely a metastatic urothelial carcinoma because of the clear cytoplasm and a range index. So it's not usual. It's not usual for lung adenocarcinoma. So in my practice, sometimes I write down my impression on the testing chart. I tell our members that I suggest it's not a usual EGFR mutation, but maybe uncommon driver events. Sometimes I got the right answer. So in addition to NGS, the advantages for using multiplex PCR in the first-line setting would be the tissue adequacy is better and easy performed. And I think the most important is the turnaround time, because often the lung cancer patients with prior infusion cannot wait for a long time. They are almost going to die. And because of the ultra short turnaround time that almost can be completed within a day, it's not possible for NGS. We perform NGS maybe twice or maybe twice in a week. So our turnaround time for NGS is 4 to 5 days. It's fast enough. But for our clinicians, it's not fast enough. So for the ultra short turnaround time, we sometimes use the PCR in certain oncology emergency in addition to lung cancer. For example, it's a very emergent case. It's a lady suffered from thyroid cancer, as shown here. And the thyroid cancer is large and grows, penetrating the trachea. So you can see on the upper panel, it shows calcification and necrosis. And here, the airway is almost totally occupied by the tumor. So our clinicians tell me that we have to determine the tumor type and better to have molecular test results within 1 week. I told him that it is quite challenging. But luckily, we get biopsy samples quickly. And it's a quick differential tumor, but based on limited morphology on the biopsy code, we suggest it could be an invasive follicular carcinoma because the subclassical feature is granular instead of ground glassy, and TTF1 is positive. And the BRAF B600 is not reliable because it shows too much background staining. So we should perform multi-gene tests as shown on the left panel. It shows EGFR fusion positive. And so the patient got the EGFR fusion diagnosis in 2 days after tissue diagnosis. And she received EGFR target therapy soon. And after that, in 1 week, we confirmed the cases with red gene fusion in 1 week. It's a CCTG6 and red fusion, a common red fusion in thyroid cancer. So on the left is the imaging before treatment. As you can remember, that the trachea is totally occupied, and on the right, after treatment, the tumor shrunk. Only here is not calcified area, but the tumor shrunk. So it's really work. And the next challenge 3, is the copy number determination. We learned that we pathologists usually need to determine the copy number for breast cancer, the HER2, and sometimes other copy number variation for NPM2 and CDK4 for liposarcoma. But in lung cancer, sometimes we have to determine the copy number variation because we have to face MET gene amplification after certain TKI treatment as a resistant mechanism. And also NPM2 and MET copy number gain or copy number loss for certain preclinical studies. However, the determination of copy number using NGS has not been standardized. Here is a complex flow chart, but I would like to show you that why the copy number determination varies from NGS and cannot be standardized. That is because, first, the panel design. Different NGS might have different areas of capture. Even in a gene, the capture region might be different. And the second, for the data processing, the read data have to be compared with the matched normal tissue in the database, which would be different between panels. And also certain correction for the data the mutability, the GC content, and the rate distribution, because NGS is somehow a PCR reaction, so it carries certain bias and should be corrected. And also the different algorithm for segmentation. It means that you have to determine whether a segment is amplified, the large segment or small segment is chromosome on-gain or only focal amplification. It's segmentation, and then you have to determine the cutoff. It's quite complex. So, based on the complicated issues, we learned for MATE amplification in non-small cell lung cancer, NGS would not be the best method. Based on the modern consortium paper this year, we learned that compared with fish, the NGS has low concordance with fish, especially for cases with copy number between 5 and 8. But unfortunately, this is the most common application for change we can identify in non-small cell lung cancer. So NGS is not good enough now, currently, to determine copy number change. So we, in our practice, we still perform FISH for those cases with undetermined NGS results. It's an example that a patient who suffers from non-small cell lung cancer with progression of the third line PKI, and he developed pleurosidin, as shown here, and a muscle infusion. Use the cell line, use the cell box from cytology, we determined that it's really a case with MATE amplification as shown by the red dots. So the lesson is that to profile the genome alteration in non-small cell lung cancer, we cannot use only one method. We have to profile by using NGS, maybe real-time PCR, and sometimes we pathologists are quite familiar with FISH. The next issue is how comprehensive the test should be. We mentioned earlier, in Taiwan, only limited number of genes should be included in the panel. But our clinicians are always looking for more comprehensive solutions. They really want to learn more. So we also learned that the transforming information, especially for gene expression, incorporated with mutation in the chain. It could be very helpful for those without driver events. For example, on the top is the information for Tempest. Tempest is an American company, and is almost the first one to introduce whole genome sequencing into a panel. It's also an NGS panel. So using the whole transcriptome RNA sequencing, they can especially useful for those of uncertain origin. So if you don't know the origin of a cancer, maybe Tempest by using RNA sequencing can tell you. And on the middle is the efforts from Japan, the LC Scrum, the largest lung cancer screen project collaborated with Amon. They provide a large NGS panel containing approximately 6,600 genes for mutation and around 300 for gene fusion and more than 2,000 for gene expression. So the expression panel here is for the immunotherapy. And then is the foundation. Foundation medicine also claims that they will have expression profiling panel for 1,000 and 1,500 genes. So based on my observation that the best practice would be if a patient with primary non-small cell lung cancer, it could be profiled by a list of non-driver genes. And the patient can then treated with targeted therapy. And after that, the response might be good, but eventually, he will suffer from disease progression and resistance. And at that time, the patient should be encouraged for transcriptomic profiling. And for those without driving events, the patient should receive transcriptome profile for the possibility to get more information of signal pathway in the profile and also antibody drug conjugated therapeutics. And with the efforts of this transforming study, we can understand not only the resistance mechanisms, but also the new targets, and also resist mechanisms, and also the clonal change. So here is an example. It's a lung cancer patient at the beginning, and he at the first diagnosis and with prior invasion. So I received this sample because the pathologist in our hospital asked me whether it could be a sarcoma. But my answer is that it should not be a sarcoma, but a pre-differentiated lung cancer. And as shown here, it's very likely the OAK positive tumor because the embryo-like shaped nuclei and prominuclei, but the OAK is negative. And the tumor cells are ugly with frequent magnetic figures. And so I performed NGS for not only DNA and RNA, it's assay from ammonia. On the left, in this case, it's quite busy, but you can see this case show NRAS mutation and a higher tumor mutation burden, and also MSS. And you can see it shows high MHC expression, high effector cells, more NK cells, more T cells, and one signature, and more Th1 signature, and more threshold inhibition. It suggests that the tumor could be PD-L1 positive, but its immune cells are already ready. If we block PD-L1, it could respond well to the PD-L1 targeted therapy. And here is another example who is a immunotherapy poor responder. You can see that in contrast to the left side case, this can show very few immune signaling, and there is almost no checkpoint inhibition. So this case appears to be PD-L1 positive, but he cannot respond to the immune therapy well. So it's quite informative. So I suggest the strategy for non-small cell lung cancer would be every patient should receive multi-gene testing, either NGS or multiplex PCR. But for those quality NGS are not available, or as for shorter turnaround time because of certain oncology emergency, or as for low cost or tissue inadequacy, usually multiplex PCR would be preferred. And for both settings, if the result is negative, we should study more and we think about the need to identify driver event, because sometimes the patients can get benefit from chemotherapy or immunotherapy. So if there is no need to know driver event, the patient can receive immunotherapy or chemotherapy. And if the patients or the clinicians really want to see the driver events, we have to profile the patient samples with large and comprehensive profile, or even liquid tests should be performed. So this is my last slide. There are 3 points. The first one is that the actionable mutation test is mandatory for non-small cell lung cancer because we have an increased number of drugs and clinical trials. So we have to do that. But tissue adequacy remains to a big issue. So a well-designed multiplex PCR could be very helpful. Actually, as I mentioned earlier, in my institute, for those patients want to receive NGS tests, more than half of them cannot because of tissue inadequacy. So our strategy is well-designed multiplex PCR, which could be very helpful. And transforming profiling is not the current standard, but it will be the standard in the future because it carries a lot of information in the patient treatment. Thank you so much.